This podcast is CME eligible. To learn more about CME, Alex, what do they do?
They can either go to the CME tab associated with this episode, or they can go to geripal.org/CME.
And on to the show. Welcome to the Geripal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we're going to be talking about unilateral DNRs. We did a podcast on slow codes not too long ago. We'll have links to that on our show notes. One of our guests was on that podcast. Alex, who are our whole guests today?
Yes, we're delighted to welcome back from that podcast Gina Piscitello, who is a palliative care doc, an ethicist, and a researcher at the University of Pittsburgh. Gina, welcome back to the Geripal podcast.
Thanks for having me.
And we're delighted to welcome Erin DeMartino, a pulmonary critical care doc, ethicist, researcher at the Mayo Clinic in Rochester, Minnesota, where the current temperature is...
-5?
-5, but it was -24 this weekend, she's saying. Erin, welcome to the Geripal podcast.
You're going to go out with a t-shirt today? It's warmed up.
No, not that warm.
And we're delighted to welcome Will Parker, who is an intensivist, ethicist, and researcher at the University of Chicago. Will, welcome to the Geripal podcast.
Happy to be here.
So we got a lot to talk about, unilateral DNRs, and something I've never heard of before, unilateral DNR orders. But before we jump into that subject, we always have a song request. Gina, do you have the song?
I do. It is Heartbreaker by Pat Benatar.
Why did you choose Heartbreaker?
The reason is that oftentimes when unilateral DNRs are done, it's because doctors and nurses, they don't want to break the patient's heart. So therefore, Heartbreaker.
That's a good one. All right, this is a fun one. Good energy. Here we go.
Your love is like a tidal wave spinning over my head, drowning me in your promises, better left unsaid. You're the right kind of sinner to release my inner fantasy, the invincible winner, and you know that you were born to be. You're a heartbreaker, dream maker, love taker, don't you mess around. You're a heartbreaker, dream maker, love taker, don't you mess around.
That was fun.
That was a fun one. Thank you, Gina.
Okay, Gina, I'm going to start off with you. We're talking about unilateral DNRs. Can you tell me what a unilateral DNR is?
So these are DNRs that the doctor decides to not perform CPR on the patient. So it does not depend on the patient or surrogate consent to the DNR order. It is physician generated. Now, the patient and surrogate, they might consent to it, but it's not necessary for the unilateral DNR order to be pursued.
So it's not during a code a doctor decides not to do the code. It's prior to the code, it's I'm going to put in a DNR order that the patient has not consented or the family has not consented. Is that right?
Yes, ideally before. Yes.
Yeah.
But Eric, to jump in, your comment about during a code is an interesting one, right? Because we end resuscitation after usually 20 or 30 minutes and say CPR is not going to be successful. Yeah. And we unilaterally decide to stop doing CPR at some point. That is an entirely clinician-initiated decision. And now with advances in technology like VA ECMO, there ultimately is always a subjective judgment that a clinician is making about whether to provide CPR or other resuscitative measures, whether you've attempted initially or not. Yeah. There's still a unilateral nature that's unavoidable now.
Yeah, and how long you keep going. Do you do several rounds or do you do 15 rounds? And at what point you may consider extracorporeal support?
I encourage all our listeners to watch the Rethinking Slow Codes podcast. We talk a lot about all of this, but in the healthcare system I work at, we can't do unilateral DNRs at all. But so somebody has to be full code. But if they arrest, a physician does not have to, and a code team does not have to code somebody if they think it is non-beneficial. So at least in our healthcare system, they're separating unilateral DNRs, which is, before the code, to during the code, saying you don't have to provide non-beneficial care. You still have to figure out, is there anything reversible? Like, did the trach fell off? But it does bring up this question about like definition of what we're thinking about unilateral DNR, because I don't think most people would think that applies during the arrest, right?
Right. You're right about that. Yeah. And I also think that what you're describing illustrates some variation that we discovered even amongst ourselves as we were collaborating and writing about that each institution that we're in handles these types of situations differently and may even label them differently.
Yeah. Fascinating. Can I ask just quickly why each of you decided like, hey, this is a great thing that we should think about and write about? We got a palliative care doctor and 2 intensivists. Erin, I'll start off with you. Like, what motivated you?
Well, I was motivated by working with 2 amazing colleagues who also think about this type of issue really frequently. I was particularly interested. I've done work on how policy variation may translate into different types of practice in different settings across the country. And so the opportunity to kind of measure that and try to quantify it, see what's written in statutes about justifications for unilaterally withholding a life-sustaining therapy. That was really what drove me to want to be a part of the project.
And have you personally done it?
So actually, that's an interesting question. At my institution, there isn't an ability to enter a unilateral DNR order. And I don't just mean labeling the order as unilateral. We don't institutionally condone the practice of unilaterally withholding a life-sustaining therapy. And so a patient who expresses, or patient or family who expresses opposition to a proposed withholding of a life-sustaining therapy will receive CPR at our institution.
Does everybody get ECMO?
No.
So there are some life-sustaining therapies that we will. Okay, well, let's hold on.
ECMO is not a default state, whereas CPR is, right? ECMO is not a default state of, anybody who doesn't have a DNR order will receive CPR, and so that is the default state.
So does the policy just apply to DNR, or is it life-sustaining treatments in general?
DNR.
DNR. Okay. Will, what got you interested in this?
Well, I think, conversations about our practice patterns, I think, motivated us too. Erin and I are often in situations where we feel like CPR would be strictly futile in the sense that the probability of restoring ROSC when the patient arrests from refractory septic shock, let's say, is essentially zero.
Yeah.
We know
that just some of our listeners are
return of spontaneous circulation. So the patient's heart stops. We can do chest compressions and give medications, and we're trying to attempt to have the patient heart restart and the circulation resume in such a way that the organs will be perfused and the state will be somewhat permanent, right? Mm-hmm. May require life support, but that's the goal of CPR. So sometimes clinically, we can be quite sure that if we do the CPR, we're not going to achieve that state because we've been taking care of the patient for days and we've sort of seen the trajectory downward. And so often kind of walk in the room and say, we're not going to do CPR. Here's why. And it's not a question. It's just it's a statement of fact from our medical opinion. And often the family says, okay. And then the intern puts in a DNR order in the chart. But as I think Gina brought up at the beginning of the podcast, that was a unilateral decision that I made as an intensivist. The family assented to my decision. They didn't say no. They accepted it. And maybe if I had asked, do you still want us to do it anyway, despite what I told you, they might have said, no, that's crazy. You explain why. But we didn't ask the question, so we didn't really know. And so I think that was one of the central things we were trying to get at in our manuscript is that we think that a lot of patients who are made do not resuscitate in critical care units actually might fall into this category of assent unilateral DNRs, which are a sort of silent practice that's not documented in the electronic healthcare record.
I want to get back into this assent versus the conflict. I think you wrote DNRs. But before we do, I just want to ask Gina the same thing. Gina, it's specifically about unilateral DNRs, like we talked about slow code the last time you were on, because you've done some research on this. What motivated you to dive into this topic?
Yeah, I think as a resident, I didn't know unilateral DNRs were a thing. And then you see them in practice and it just like blew my mind. Because I always was taught in medical school, you offer the options to patients' families, they decide. Yeah. And then to see that that is not the case in practice, and then hearing from people, across the country, how practice differs so, dramatically. I think that's been my passion, just been kind of like empirically assessing what is happening. Because I think, these are really difficult decisions. These affect patients and families greatly, as well as the medical teams. I just think we should do this the best that we can. And in order to do it the best that we can, we need empirical data to, identify what we're doing.
Speaking of confusion across settings, Eric and I are at UCSF, and our trainees, they move between different hospital systems. So like at UCSF's main hospital system, there is a pathway for a unilateral DNR, and there are specific procedures that you have to follow and discussions and ethics committee consults, etc. At the VA, as Eric said, there is not. And so our trainees, just within the same, training system, they get confused sometimes, and they're like trying to institute a unilateral DNR in a system where that is not allowed, and we have to do education about that. Much less like the variation you found across the country and across different systems. Go ahead, Eric.
So I understand unilateral DNR now. What's the different types that you put in your paper?
Yeah. Well, did you want to describe it?
Yeah, I think the main two types we identified basically by just analysis and thinking through what are the possible scenarios is in assent unilateral DNR. That's that scenario I just described where the clinician comes into the room and says, we are always imagining a critical care unit in these settings. So, we are not going to perform CPR. Here's why. Explain the reasons empathetically, use our best bedside manner, obviously. And the family sort of assents to that. But they haven't actually been given the choice about performing CPR or not. In contrast, a conflict unilateral DNR is that same scenario, except the family says, no, I reject your reasoning. I want my loved one to receive CPR. You have to do it. And so the latter one, I think, is what most people think of when they say this is a unilateral DNR. But part of what we're trying to argue in the paper is that the assent unilateral DNR is equivalent in many ethical respects.
How so? Because, I feel like this happens all the time. Hey, we're stopping your Zosyn. Hey, the EEG monitor we're pulling off today. We are telling people the plan. They can certainly dissent to it, but this is happening all the time. Why are we putting CPR on such a high pedestal that we are asking family members to make this decision when there is no decision? The patient's dying either way, especially in these unilateral DNRs. It really should be in people where it's.
But are they? I think that's a question.
Because, do we have data?
Well, how good are we at prognosticating, even short term? And so I have some experience with this because I work in an institution where we can walk into a room and make a statement saying that we will not offer CPR with some additional. I think it's important to say that the choice architecture here matters, and that giving the family space and time and a supportive environment to voice opposition, so that they do have that opportunity. I think it's critical that we not just plow over them with that recommendation, but we actually give them the time and space to react. But that said, I work in an institution where if there is opposition to the plan, CPR will be provided. And it's interesting to hear Will's description of what happens in a code. A lot of the codes say in the medical ICU, the patient's heart hasn't stopped. It's beating. It's pulseless electrical activity.
Yeah.
We can't feel a pulse. And so it's on the continuum already. So we are trying to, what is return of spontaneous circulation? In a code setting, it's a palpable pulse. Because our patients already have arterial lines. We can see that they're, or if somebody throws an ultrasound probe on, we can see there's still cardiac activity. It's just that we can't feel the pulse. And that's kind of what, through ACLS, that's what we're trying to regain a pulse.
Can I ask you though, Erin? I'm going to go back to this. Like, what's different about CPR? Because, like, many of us will not offer things like dialysis. That's tricky. Depends on which renal attending is on. But you may not offer things like dialysis. There are other life-sustaining treatment. ECMO, we don't even mention 99.999% of the time. What's different about CPR in somebody who looks like it's not going to be helpful, that we feel like we have to have the family members say, I don't want this, versus everything else, like we're also bearing the burden on our shoulders?
I mean, I think they're all life-sustaining or circulation-sustaining treatments. Like if you're manually compressing the chest and forcing blood around the circulation because the pulse has dropped low enough, that's a different way to achieve what VA ECMO does.
Yeah.
Dialysis is, preventing a cardiac arrest from severe acidosis hyperkalemia. Yeah. So I think, Eric, your point is that there are some areas of medicine where life-sustaining therapies are withheld unilaterally just for cultural reasons, not necessarily for ethical ones. Yeah, or historical reasons. Yeah.
Medical reasons, not necessarily. It's historical.
Yeah.
Gina, what do you think?
Well, I think, Eric, to your previous point about, like, do we have data about how often this is happening? We can say, like, during COVID, we looked at 2 different hospital systems during COVID, and patients in the ICU on vasoactive agents, 3% had unilateral DNR orders placed.
An actual order that said unilateral DNR.
At one hospital system, yes, because they had the order. The other one, it was within the notes. Within the notes, it said that this is what we were doing, but it would be a regular DNR order.
3%.
3% of patients in the ICU on vasoactive agents during COVID. Yeah.
Can I ask you, do you know how many of those people survived to discharge?
1, I believe.
Oh.
Yeah, no, that's an interesting point because, if a patient was not an ECMO candidate, so setting aside ECMO, for example, during COVID, they're on, and then the whole ethical decision of who gets ECMO, who doesn't.
Yeah.
So assuming that the ECMO team's not going to do ECMO, if you have a patient who's prone, paralyzed, and multiple vasopressors for severe COVID pneumonia, those are the type of situations where I think CPR could be medically said to be strictly futile. You'd have to flip the patient over when they have code with the cardiac. I mean, it's not going to work. But then sometimes those patients would get better, and you have
One survived to discharge.
No, and I remember distinctly having a conversation with a family member after having gotten an assent DNR earlier and saying, well, he's doing better. Like, we're able to unparalyze him and supinate him today. So he's no longer DNR, right? CPR wouldn't be strictly futile. His clinical status has improved. And then his, wife said, oh, thank God, I never wanted to be DNR in the first place. And that's what sort of made me realize that this assent DNR practice is probably very pervasive across medicine. And, I do it. So
I do it all the time. So I have, and we teach this in like Vital Talk training and communication training, is that, relying less on menu options for everything we do in medicine. Like, do you want X or do you want Y? We talk about illness understanding and prognosis. We talk about goals, what's important, what you're worried about, what you're hoping for. And then we align with those goals and make a recommendation. For example, like what I said this week was, it sounds like what's most important to you is your comfort. We're going to do X, Y, and Z to make sure that, in continuing things like your antibiotics, so living longer is important. And if things don't go the way we hope, we're not going to do things like send you to the hospital or do CPR. Does that sound okay? Or I'm just going to say, does that sound right? I'm not giving them menu options.
Yeah.
That is probably closer to assent. Like, they actually have to now, like, this is choice architecture. Again, I we'll have a link to our nudging podcast around choice architecture, but we're nudging people towards agreeing to this. Is that okay?
I think you can't just walk into a room and do that. I think you need to have rapport with the family. You need to know something about the patient and their values and preferences. That's an important element here, is that you can't just, hear your sign out rounds in the ICU and be like, boom, that person should be DNR, and then go in and have that conversation quickly. Yeah. That's what I'm talking about, like kind of the time and the space and developing, investing in the rapport with the family.
And I've definitely seen that, and it does not go well.
Does not go well. You got to do the relationship first, so you can talk about the hard things. Then you can talk about shared understanding of prognosis, understand what the goals are in view to that shared understanding of prognosis, and then offer a recommendation. So yeah, it's a longer process, and that's in our practice of palliative care. It may differ in like emergency medicine, critical care, patients crashing, you're just meeting them on the floor for the first time, and you're talking to family members who you'd never met before. That's a different sort of situation. I also worry about I don't know, I guess I want to push back on the idea that we should separate the assent, unilateral DNRs, and sort of categorize them anywhere near the unilateral DNR, terminology. And maybe that's because it's such a part of my practice and I feel perfectly okay with it. Whereas unilateral DNRs, I think there's some disagreement, as we can see. Ethically,
you mean the conflict unilateral DNR,
morally, and I don't want it to land anywhere near that uncertain ethical territory, to be frank. And I feel like from a patient's perspective, a lot of times we're unburdening family members who they can't say the words. They just can't say the words, though they may agree with the underlying principle. And I don't want to have to be in the position as a clinician to be forcing family members to say the words in order for it to be a true DNR rather than a unilateral assent DNR.
Nor do
I agree. I think I think this assent UDNR practice is ethical with some of the guidelines that Erin was guardrails that Erin was. I don't know if Gina agrees, so I kind of want to throw it over to Gina about that statement. But I don't think the assent UDNR practice that a lot of us engage in with appropriate guardrails is unethical. But maybe Gina disagrees.
Gina?
Well, I'll just say that I think with the framework within palliative care, how we try to assess patient values and preferences and align treatment options with that, it's still there's a huge power differential between the physician and the patient and the family members. And some patients and families, they don't feel they have any ability to speak up in those conversations. So I think, what Erin was saying about the relationship building is so important. But with all of this, can I as a physician really know the lived experience of the patient and family member in front of me? Can I truly help align? I can do the best that I can, but I think there are times where I fail because I have my own lived experience, my own judgments and things. I have seen these unilateral DNRs. So in our study, it all looked like it met criteria. They were strictly futile. CPR could not work in those situations. But I've seen outside of that study practices where a patient is on the floor, not on life support, and they're doing a unilateral DNR. That patient, you haven't even tried yet to, life support for this guy. So I think it's these concerns about we're not just doing unilateral DNRs on people whose CPR would not work. We are doing it on people who we think, I just don't want to do CPR on this patient. It's just, my moral distress is so severe that I just can't do it for this patient. And I think that's where the real concern is about these unilateral DNR orders and, making sure that we document them so that we are aware of them as a clinical team and the patients and surrogates are aware of it as well and they can speak up because we aren't just doing it in these strictly futile cases.
But, the person on the floor, we're also doing that for a lot of other life-sustaining treatment decisions, like dialysis. Why, again, I'm still stuck with, why CPR?
Yep. I have an issue with dialysis, too. I have an issue when that's that that's applied differently to different people. And it's a real issue. That's something we should be discussing as well.
You have a little data on variation on unilateral DNR, don't you?
Yes. And so for our study, and I want to shout out because a lot of people help with this paper, and Mike Huber, who's also palliative care. I couldn't have done it without him as well because he looked at all these statutes with me. We looked at all statutes for all U.S. states and District of Columbia about how do you address unilateral decision-making for any form of life support, including dialysis. So for that, we found that 49 states, at least somewhere in their statute, they allow clinicians to decline to initiate or maintain at least one form of life-sustaining treatment, which could be dialysis, could be CPR, could be ECMO.
Yeah.
But they're all over the place in what justifies that. Some states, it's like, well, you need to have a medical reason to justify it. Other states, it's you need to have a reason of conscience to justify it. The medical reasons are all over the place. Some, it's like medically inappropriate. What does inappropriate mean? It needs to be standard of practice. What does standard of practice means?
Yeah.
So basically, all over the place.
Yeah.
Mm-hmm. And why is that a problem?
I think I'll answer this, and I'd love to hear, Erin and Mo, what they think. For me, I just want patients to be able to have, the best system would be a system where we are uniform in what we're doing, and patients and their family members have a way to advocate for themselves when care potentially doesn't align with their values and preferences that, potentially could work for them. I think that there's so much variety across states. I mean, there's just no way to know really what works well in a way because we don't have a standardized mechanism for, what we're doing to begin with.
Right, but that patient's they're in that state. And states may have different, this is the states' rights versus federalism issue. It's not as if they're maybe it happens rarely as they're transferring across state lines, or maybe they intentionally transfer across state lines because there are different rules in different states. But that's pretty rare. I guess I push back on the notion that state-level variation in and of itself is a problem.
Well, I think the point is it's arbitrary variation in these rules. There's a lot of variation between states because no one has a clear right answer for these rules about unilaterally withholding, withdrawing life support. And I think one thing that Gina articulates quite well in this is that if you're withholding a life-sustaining therapy, you better have a clear reason. And that reason can't be just because the person doesn't speak English, which is what Gina found in her paper.
We want to hear more about that.
Yeah, we can talk a little bit about that. But I think to talk about the dialysis case, when the nephrology attending decides not to offer dialysis, there needs to be clear documentation of why that life-sustaining therapy is not being offered. And it could be that the burden of going to dialysis 3 days a week and this frail patient and all the complications that is expected, that burden is too great to justify the risk of, or the potential benefit rather of actually having their renal failure treated. But, you need to own up to that. There needs to be an argument made and an explanation given to why it's not being offered.
So it's really more the problem. Oh, Erin, go ahead. I know you've done thinking about this. I know you have a NEJM paper about state level variation and surrogate decision making. You've done work about variation in allocation of scarce resources during COVID. Is it the variation that's a problem, or is it that sloppy sinking in some of the states?
It's the arbitrariness that Will is saying. If we could prove that they reflected principled differences that reflected the populace of those particular states, I don't think I would be troubled by it. But these aren't distillations of the values of the people of one state versus another, or at least we have no reason to think that the variation we're seeing here reflects in some way community engagement, or even really maybe even medical communities' engagement around these topics. They just look pretty arbitrary. And, when the decision to withhold a life-sustaining therapy hinges on a clinician's interpretation, many of these don't even have oversight mechanisms. So a single clinician's interpretation of what the standard of care is, and they can unilaterally withhold as they see fit. Also, we haven't talked about qualitative futility assessments and what goes into those assessments. So there are a lot of different ways in which there are opportunities for clinicians who wield so much power in this overall dynamic to withhold a therapy that would be desired by a family and that may, however slim the chance, that may have some hope of helping the patient survive the hospitalization.
Can I ask, we were talking about statewide variation. Gina, it was alluded to that there may be variation amongst which populations get unilateral DNRs?
Yeah, so during COVID, that study where we looked at 2 different academic medical centers, patients who are Spanish-speaking were much more likely to have unilateral DNR orders placed compared to their similarly ill patients in the ICU.
Do we know why?
Well, we had some hypotheses. One is, and I know like the teams there, like people were trying the best that they could to try to reach families. Sometimes it could have been that they couldn't just reach the family, so they put the order in. Other times, I think, trying to get an interpreter on the line. We weren't doing in-person interpreters back then, like they were virtual. So I think it probably was a language barrier. But I will say that in my experience, I saw similarly ill patients who would have qualified for a unilateral DNR order who were not Spanish speaking, and they did not have it placed.
Yeah, we're humans and we're biased.
Yes.
I'm going to go back to conflict unilateral DNRs. Is it reasonable to have them, Gina? Is it ethical to have them?
I think for a patient who there truly is no way CPR is going to medically benefit them, it is truly physiologically futile. I think that the honest thing for physicians to do is to tell the patient and family members, I am so sorry. CPR cannot work. This is all the other things that we are going to do to help support you. But this one thing will not work for you. I think we need to be telling the truth. The alternative, Eric, is we're going to slow code them, right? Which is not a good, in my opinion, it's not a good option. But I think for those situations, I think it is better to tell the truth and not do CPR than to lie and to do CPR on a patient that we know it's not going to have a medical, it cannot medically work for them.
Yeah. What if the family still wants CPR? Because there will be the family that still wants CPR.
I am in favor of a short code, a real code, but maybe it's not a code that lasts 35 or 40 minutes.
You call it when you think it's no longer beneficial. That's what happens in like the VA system. You call it when it's no longer, that's what should happen.
I think a lot of families who are requesting that really want full gas life support and critical care treatment up until the line, right? That this assurance that you've really done everything possibly could for the patient that has a probability of success. So we know that patients who have DNR orders are less likely to get other aggressive treatments that may have benefit. So I think particularly on the south side of Chicago, there's a lot of earned distrust of the healthcare system. I think that's where it comes from, is that if I make them DNR, they're not going to try to save him, right? They're just going to let him die. And so I think walking up to the line with families, in my experience, allows us to reach consensus on no CPR when they sort of establish that rapport and they see that we've gone to the mat for the patient and tried everything that was reasonable.
Do you feel like they want us to go up to the mat, or do you feel like it's part of their advocacy? They need to advocate for us to go up to the mat.
I think they want their loved one not to die. And
right? Who does?
Right? And there are families who, for very good historical reasons, are mistrustful that their loved one is getting that treatment, the state-of-the-art treatment, even if you are at an elite academic center, because of the types of biases that Gina has described in her work. So, I think it's this idea that we're gonna let their patient die so then we can take their organs and give them to our rich patients. Those ideas exist, and I think the only way to counteract that is really to be present with the patient. And in the critical care unit, that means like being at the bedside, trying a lot of different critical care things. Yeah. So that's how you.
To get back to your question about like the ethics of all of this, I think there are circumstances where, the assent UDNR is unethical. And I think there are circumstances where it's ethical. It's all in the way that it is, that the strength of that conversation. I personally don't believe in conflict UDNR. I've never practiced in a place where that was possible. And I question our ability to even predict these short-term outcomes. And the reason why is that I have colleagues who will try really hard to walk a family through an assent UDNR. The family wants to continue with keeping the patient full code. The patient loses a pulse. And so a lot of smart people think that ROSC would have been strictly physiologically futile, and the patient regains a pulse after 5 minutes of resuscitation.
Yeah.
So, we need to be really strict and really disciplined with our use of the word futility and acknowledge when it is a qualitative judgment versus when it's really a physiologic judgment, because sure, the Crohn's patient who was on 3 vasoactive
basically
agents
getting
who has
coded already.
ARDS. Yeah, I mean, like that's a situation that we see sometimes. But then there are other situations where the outcome wouldn't be quite as perfectly predictable.
Yeah.
And yet there is real strong arming to try to achieve a certain outcome of code status. Again, this gets back to kind of the culture around the default CPR for every person falls in the United States, falls ill in the United States, but that's the culture that we're working within. And so I have seen these patients who in any other institution would actually have been made DNR unilaterally, who regain a pulse, and sometimes they also survive the hospitalization. But if we're talking about, as Will said at the beginning, what's the objective? The medical objective of CPR is to regain spontaneous circulation, return of spontaneous circulation. And sometimes these patients who wouldn't have received CPR in another institution do have ROSC and do survive.
So I got to ask a question, because your article poses something that I've never heard before. Again, we'll have linked to this article that was published, I think, January of last year, addressing inadequate documentation of unilateral DNR orders. So, Gina, I'm going to ask you, is that you argue that current documentation, like even if you can do unilateral DNR orders from a conflict perspective, and sounds like a lot of us use assent unilateral DNRs, what's wrong with how we currently document it in our EHRs, electronic medical records?
I think the concern is kind of, when these patients actually do improve, if you just put a regular DNR order in the chart, you don't know who consented to that. Was that the patient's preferences to begin with? Or were the patient's preferences always for full code and the doctor was the one that decided for the DNR order? So I think there's multiple reasons why it'd be great to have good documentation, but one of the big ones is for that patient who improves, we need to readdress it. And I feel like the only way that we can know to readdress it is an order. If you wrote in your note, in your like palliative care note or critical care note, one day, like we're doing a unilateral DNR order for this reason, who's going to look back weeks in the past to find that explicit note that said that? It's just so likely to get lost. That's why having it as an order, and I've seen in practice at one institution, I've seen the unilateral DNR order is a true distinct order.
It's an order that's in the chart.
Yes. And part of it, the benefit of the order being there is it also has this institution requires specific things to be met that you must tell the patient and surrogate that you're putting it in. And so this order requires you to say that you did those things in order to sign the order. So it kind of is protected in that way as well.
Is that true conflict and assent unilateral DNRs? Just conflict.
That would be the ideal. Because I think it's important to know, like, was there conflict behind this? But I also think it's important to know what were those patients' values. Number one, that is what we are here for. What are those patient values? That should be documented somewhere.
But we don't do that for other things. Like we don't have a UZOSIN order. Like we should always be rethinking all of the orders that we put in. And even if a patient wants us to start an antibiotic, but we don't think it's going to be beneficial, like we're not going to put in like well, I
don't know, Eric, I'll push back on you about that.
Yeah.
Like we oftentimes as a palliative care team, we discuss code status at the end of a long family meeting conversation.
Yeah.
We've gotten to know them, make a recommendation. We agree on DNR, or they assent to DNR. And then we're like, oh, please don't readdress this with the family. We don't want the primary team to readdress this with the family. We don't want like some like ER doc who's just meeting him for the first time to say, hey, if your heart stopped, would you like us to initiate chest compression?
Would you like us to restart it?
Yeah. No.
So, there is some like, I don't know, do we really want this? We want it readdressed thoughtfully at the right time. Is that going to happen?
Yeah.
I think the difference between, go ahead, Erin.
Well, we have an obligation. If there has been a unilateral decision that has been foisted on a family, we have an obligation to revisit that as the patient's disease trajectory plays out. So if the clinicians are accurate in their prognostication, then the patient will die in the hospital probably in pretty short order if, we're thinking about a measure like a unilateral DNR order. But if they do not, and this happens all the time, ICU survivors are coming out onto the floor and there's a DNR order trailing them. And you try to talk to them about it and nobody has any recollection of what the circumstances are, or they do recall it. And like Will was saying, they're horrified that it's still in the chart because yes, there was that one really dark night where it looked like they might not make it through the night, but they turned the corner and they got better.
But isn't that an argument that everybody should be like we should be readdressing code status for everybody who's getting better?
Of care. Yeah, definitely. Yeah.
But I think it's like the distinction of having a different order would be like this. A standard DNR is one that is consistent with the patient's values, that they have chosen this. They have these red limit lines around what kind of medical care they want. I mean, I always tell the residents in the MICU, like, there are a lot of patients who don't want life support. You don't see them here in general. Like sometimes they make it here despite their values and preferences, but you have to assume if a patient is in the MICU, they want you to go full gas. And so I think when a DNR appears in the chart, the assumption is made is that it reflects the patient's values and preferences. But if it wasn't a set UDNR, that may not be true. And so that's, I think, what one of the important points. And I think the difference between a CPR and life support and Zosyn is that it's sort of the last thing that keeps you alive, right? Strictly fetal Zosyn is not gonna prolong your physiologic life at all, but CPR, ECMO, and dialysis will.
Will, is the opposite true? Like we have a full code order in our chart. Should we have a unilateral or default full code order just to highlight that we have not yet figured out whether or not this full code order is?
It says assumed full in ours.
Yeah, we do.
Assumed full.
Yeah,
not verified, not known to be consistent with the patient's values. No one's had that conversation.
And then it switches to full.
When someone actually puts the order in for full, which sometimes doesn't happen because everyone just continues to assume full.
You got to do another article on that.
I think Mike Huber created that, who we referenced earlier, palliative care physician at University of Miami. So, but that's the way it works at University of Chicago to reflect that. But I think that it's the default because if you don't do CPR, then the patient will die, right? If they suffer, a cardiac arrest or PA. Yeah. So I think that's why the paradigm's evolved. It's not that complicated. But yes, we have this assumed full.
We don't have it as an order, but anytime we write admission notes, we write presumed or like must confirm or whatever to make sure that people know, that we haven't been able to reach family or we haven't been able to discuss it with the family. So absolutely the same principles apply.
Okay, Erin, the other thing that I loved about your article, which I'd never thought about before. So you're kind of against conflict UDNRs, it sounds like. There's this question that you brought up in your article, all three of you, about whether or not UDNR orders will normalize unilateral DNRs. Tell me about that.
That came from me.
Did it?
It did. Yeah. Well, because I think it's exactly that concern. Is there a slippery slope that once people realize this is part of the admission order set and boy, look at how sick this patient is and how much they've already been through. Wow, I can just say that we aren't going to give the patient CPR and we can save the team the moral distress of offering a therapy that could be hard, that could break their ribs. I'm worried that it would be used and abused. And then it might also, again, getting back to Gina's already demonstrated empirically that it's used differentially for different populations.
Gina, are you worried about it?
I'm very worried about it. But I think, it's already happening in practice. I just feel like we should just focus on helping to make this better. It's happening in practice. We disagree about whether it should be done or not. But what is being done, we need to do something about it. And I feel like we're really not addressing it. We're just letting it happen and there it goes. And that's not great.
Yeah. It is interesting though that we don't put reasoning behind any other order. An order is just an order, right? For pharmacy meds, we have indication of when to give a PRN, but there's no how we came up with the order, process, intention to any other order. Is that right?
Yeah, I think it's in the ICU, we do tons of things to the patient in rapid fire, right? Without consenting each individual treatment. I think the standard ethical theory is that they've consented to the ICU care as a package. They may not be consenting to each individual item, but they're in for a general course of life support treatment, and
or
then they
it's
give
the
you
default pathway that they're in until
true. Yeah.
So there's a nudge.
Yeah, we may not have gotten that general consent for the life support, but I think that's at least the theory is why you don't have to get might have these discussions about every little detail.
And to borrow from our mentor, Dr. Siegler, we err on the side of life until we know more about the situation. So yes, the patient, once they're admitted to the ICU, they're kind of on a path to receive lots of different interventions until we hear otherwise from them. But that doesn't mean that we don't check in with them very regularly about how this aligns with what they expected or hoped for. So there are many exit ramps short of getting to the end where we're talking about a unilateral order not to resuscitate.
All right, my last question to all three of you. If you had a magic wand, you could change one thing around our healthcare system or what healthcare providers do around DNRs, unilateral DNRs. What would you use that magic wand on? Erin?
I guess I've already kind of said that my biggest concern is around the definition and looseness with which we throw around the word futility.
Yeah.
And that it ties in very neatly with my concerns around unilateral DNR orders. So being really strict and precise about using that word for physiologic reasons and only in the most dire cases.
And not like qualitative futility. I don't think their life is good enough to do.
Who am I to say?
Or quantitative, like what number how
Exactly.
low of an odds that
Who am I to, just because I went to medical school, why do I get to make that judgment?
Yeah. Well,
yeah, I think documentation of reasoning for withholding of life support therapies would help. When a surgeon makes a decision not to take that patient with acute abdomen to the OR, they've got a whole long note about why they're not doing it. And you may not agree with the reasoning all the time, but it's there. So I think for too many life-sustaining therapies, they're withheld without an explicit justification for why.
Yeah, I love that. And maybe making it a place where people can find it, like a special life-sustaining treatment. Now, Gina?
I would say in addition that when these, orders are placed and, it's a law by hospital policy, state law, that we really focus on supporting the patients and families through this, make sure that we're transparent and allow them to have the advocacy that they should have when these decisions are made.
Can I ask you a quick question? Texas has a pretty lengthy statute around this, right? That there is this. Is that like a model, you think? When
I saw Texas, I thought this is fantastic. But is it actually being used? When I've talked to people, and I'd love, to hear feedback from people actually in Texas, I've heard there's very limited actual reporting of this data happening. But it looks like a great model.
Because there's a 10-day period that they can find different institution to care for them. There's
well thought out.
Yeah.
Right.
Well, maybe that's saved for another podcast. Any Texans listening, if you want to do another podcast on that, let us know. But maybe we'll just end with a little bit more of
Heartbreaker.
You're a heartbreaker, dream maker, love taker. Don't you mess around with me. Heartbreaker, dream maker, love taker. Don't you mess around.
Wonderful. Will, Erin, Gina, thanks for being on the podcast. That was wonderful.
Thanks so much for having us.
Thank you.
And wonderful article. We'll have links to it on our show notes. And to all of our listeners, thank you for your continued support. We'd also like to do a brief shout out to those listeners who've donated more than $250, including
Kate Mesrich, Jen Hopping, S. Ashad Abid, Michael Bordowski, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Bragman, Elizabeth Chung, Paul Amatelli, Brian Cassell, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Simoji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Carrie Levy, Mamie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Nayak, Xinyi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews-Wren, Elizabeth Cobbs, Amy Rack, and Meg Walhagen.
Your support keeps the microphones running, so thank you very much.